Good evening, everyone, and welcome to another sensational eye care webinar. Tonight, we have an amazing program for you, how to enhance your daily patient management with wide field OCT. You will learn from the experts how OCT and OCT angiography can help you in your patient management. But first, let me introduce you to one of our speakers, but as well the moderator for this evening, Professor Paulo Stanga. Professor Stanga has over 32 years of experience in ophthalmology and specializes in medical and surgical retina, macular degeneration, diabetic retinopathy, vitreous floaters, cataracts, retinal laser, R&D new therapies, surgical technology, and advanced imaging and clinical studies. And he is head of the Retina Clinic, London in the UK. But also in his talk later in the program, he will present on how to assess the vitreoretinal interface to establish the status of posterior vitreous detachment and objectively diagnose the absence or presence of a partial or full PVD and quantify it. So I will give the word to Paulo, and the floor is yours.
Thank you very much, Ori, and thank you very much to Canon Europe for organizing this webinar, for this invitation and the opportunity for the four of us to present to you today our experience on wide field OCT, either cross-sectional, 3D, navigated, or angiographic. As we know, OCT is not a new technology. It's been around for decades now. We started using it in the UK in 1998, starting with time domain technology, moving through spectral domain, and then swab source technology. And now we are benefiting from the newly developed wide field single scan OCT technology that we are using. So it is a pleasure to share this webinar with three very well-respected colleagues. So without any much more delay, I will introduce the first two speakers. The first two speakers are from Manchester, Professor Tariq Aslam from the Manchester Royal Hospital. His current research explores the psychological aspects and the potential for computerized and technological enhancement of patient care. Dr. Orlaith McGrath, a clinical research fellow at the University of Manchester, who's carrying out an MPhil in ophthalmology in technical applications with the University of Manchester, is working with Tariq. So both of them will speak about OCT angiography as a window to COVID-19, a very pertinent topic at the moment. So Tariq, Orlaith, thank you very much for joining us. Tariq, we look forward to hearing you.
Thank you very much, Paulo. So it's a pleasure to be here, and thank you very much for inviting me again. And thank you for that introduction, Paulo. I can see from the agenda, there's lots of really interesting clinical presentations coming up later. I'm looking forward to seeing those. But I'm going to start with a slightly different tack. I'm going to look at the application of OCT-A technology for research purposes, and specifically to look at the potential for OCT-A analysis to unlock secrets about systemic disease. Now, whenever there's an exciting technology, there's always a big rush of people to apply it, people hanging on, jumping on the bandwagon. And so this is just a paper just to show that actually this has been going on for quite a while now. This is a paper in 2005. Now, I always have a rule, if I ever present a paper of mine that's older than somebody in my audience, it's time to retire. So I think I'm okay here, but I'll have to keep checking back every so often. But this is a paper from 2005, before all the exciting OCT-A technology was widely available. And even back then, there was a lot of interest in the potential for retinal vascular image analysis to unlock information about systemic disease. And there's been a lot of work that's looked at the correlation between retinal vessels and cerebral vessels, mainly because of the unified embryological nature of their origins. But it's not only cerebral, but cardiovascular disease as well. And here we see actually some of the associations made with even conditions like Crohn's disease and other inflammatory conditions such as Behçet's disease. So there's a lot of potential that is there and is published in the literature. Now, there are different approaches to this. We could take a machine learning approach. We want to do something about with the images that it's beyond just clinical assessment. Sometimes especially the deep learning systems, and certainly machine learning in the machine learning area, takes a lot of images, maybe thousands or so of images, which we haven't been able to access. We've only got access to less than 100 images. So for our work, we've developed an expert system, essentially whereby retinal specialists have looked at the images and thought about what aspects of those images might be most useful to assess, and then coded software to extract that information. The coding is reasonably complex because in terms of imaging, the computer doesn't see actually an eye here. It sees essentially a matrix of different values. So in a grayscale image like this, in the computer's mind, it's just a massive matrix of numbers of different intensities. So you have to then write code that translates this matrix essentially to give an analysis that you're looking for. And there's lots of different ways of doing this. There are books and books that have been written about image processing and analysis. But for example, if you apply this sort of matrix with a central point in the center that's higher, you get an algorithm that enhances tiny points. Or you can enhance lines in a certain direction with different algorithms. And then there's aspects called morphological operations. And you can see these images on the left. The top one, between the top left and the top right, is a thickened image, and the bottom left and the bottom right is a thinned image. And you can imagine a variety of different ways you can remove or add to images until you ultimately can enhance an image to just show the areas that you want to look at, and then move to the next stage of measuring those areas. So we've done this in Manchester with software provided by this platform of MATLAB, which is a sort of uniform and universal, well-respected image processing suite. And this is an example of some of the lines of code from our software, which is similar, if those of you are used to programming, to the C or C+ language. And this is a video of it in action, just so you can see what it entails. So essentially, I've already opened up my MATLAB software, and I've just pressed on an image, and there you see masses and masses of processing and the resulting image from each of those steps. And then the final image, where the larger vessels are encoded, the smaller vessels are encoded, and the foveolovascular zone and paracentral areas are also located. And that's all taken a few seconds. And you can see from this that it's been entirely objective, so no user input. And that process leads to very, very powerful systems of measurement. So what do we get from this? From this, what we see is that we have found a few key metrics which were most important. Rather than foveal area, which can be quite a noisy measurement, we found that ischemic areas adjacent to the fovea were very important in delineating those who had diabetic damage. Also, the mean intensity, not just of vessels overall, but of the smallest vessels. And then finally, the skeletonization percentage. Skeletonization is if you took every vessel and reduced it to just a single pixel width. And when we looked at this, we assessed the ability, the power of this image processing and analysis to differentiate between diabetic and normal patients, and diabetic patients requiring treatment, and those diabetics without any disease, and found quite decent areas under the curve for differentiating these using not only machine learning, but also basic statistical methods. One example of a machine learning method that I thought was quite nice is this decision tree. And the reason this is nice is because as opposed to the black box that you sometimes refer to in AI, where you just get an output, this decision tree allows you to understand how the computer has come to its conclusions about differentiating different patients. So here we can see it first looked at the areas adjacent to the fovea, and then it looked, for example, at the average placental skeletonization, and then it looked at things like mean capillary intensity. And finally, you get from the different decision tree branches down to a diagnosis of normal or diabetic. Now, the next stage in what we've done, that was work done on smaller OCT-A systems. And the exciting thing about the Canon was we had the opportunity to expand that. We've looked at it in diabetes and presented some really useful information in diabetes. But to be even more useful, one of the things we wanted to get our hands on was the Canon system for 3 reasons, essentially. Firstly, the intelligent denoise process that they have. And that's a system by which is used in other imaging modalities. So here you have a denoising of an MRI image. And essentially what they do in the Canon system is that they have developed a neural network. It's been trained on images of OCT-As, which have been averaged to get an absolutely optimum quality. And then you have a basic image and this highest quality image, and multiple sections of the images are trained using those two to try and detect where are the points of noise. When you have a final algorithm, you can apply that algorithm to just a basic image and enhance it by removing noise to this quality here on the bottom right-hand side. So here you see some examples. A standard OCT image is at the top, and the enhanced images, which you can see and I'm sure agree are much better at the bottom. And we've not just taken this for granted, we've done some clinical studies that showed the benefits of this processing and the fact that there isn't any loss of clinical information. The second great thing about the Canon system is that you can easily access the binarized image, which is the image where all the pixels are either 0 or 2.5 or the maximum level. So 0, 1 essentially. And this has been really helpful in the programming because having access to this on this skeletonized image of this is really useful to act as a double check on my own algorithms for extracting vasculature. And then finally, perhaps the most powerful thing is we really wanted to get a wider area than just the 4x4. So we now have access to 10x10 and 4x4 image analysis. And so these are the typical features we found. We're able to extract the major vessels, capillary intensity, density. We're able to get some values for skeletonization and look at all sorts of ischemic zones. This is the 10x10. And then with the 4x4, we get we also input that into the software because it just gives a much more accurate view around the fovea. The software allows us to not just look at the foveal avascular zone size and shape, but also areas around it. Now, I'm telling you all this not just because because I want to tell you the software we've done. I'm also very happy to hear from anybody out there who wants access to this software, because we're very happy to collaborate with anybody who has this sort of system or this sort of image and either do the analyses for them or try and provide them with some of the software if they've got any interesting studies they want to do. The 2 areas that we're looking, we want to expand our studies in diabetes. And this has been restricted a little bit because of COVID and one of our fellows who's had to leave, but we want to look at the wider field OCT-A and see if we can find ways of predicting neovascularization or other diabetic complications. And another really interesting area is in pregnancy, where we're collaborating with our obstetric colleagues on this study where we're essentially looking at the eye as a vascular window for obstetric diagnosis and management. in the initial stages, looking at how retinal choroidal microvasculature changes during normal and higher risk pregnancies. But ultimately, if we can try and detect preeclampsia or even assign pregnancy risk, looking at ophthalmological metrics as well as existing obstetric tools. So this has really just been an introduction to Orlaith's talk, where she's going to talk about one of the studies we have come to a conclusion on, and that's looking at these tools for the application of in COVID disease. So I'm going to pass on to Orla now, and I'll stop my share. Thank you very much, everybody.
Hello, everyone. So my name is Orlaith McGrath. I'm a clinical research fellow working in Manchester Royal Eye Hospital with Prof. Tariq Aslam. So thank you very much, Tariq, and thanks everyone for having me to speak this evening. So the aim of our research today was to figure out whether there are any changes to the retinal microvasculature caused by post-COVID syndrome or by long COVID. So our thought process was that if there were changes discovered, then that could say that OCT-A is a potentially quick, non-invasive diagnostic or screening test. And if we don't discover any changes, it could enable us to reassure those suffering that any changes are not actually long-standing. So while the pandemic may have calmed, it has left millions suffering in its wake. 1 in 10 who get COVID will develop post-COVID syndrome. There are reports of more than 2 million adults in England alone suffering from post-COVID-19 syndrome. And so it's hallmarks of chronic fatigue, dyspnea, brain fog, inflammation, and myalgia pose significant medical, social, and economic challenges. So OCT-A could provide depth-resolved imaging of blood flow in the retina and choroid with microvascular detail that exceeds the capability of other forms of imaging. The orbit provides us with a non-invasive opportunity to assess the systemic circulation in vivo. Findings reported in studies so far suggest that OCT-A parameters may reflect the microvascular changes occurring elsewhere in the body in less accessible organs such as the lungs or the kidney. If we could identify those with microvascular damage post-COVID, this could help with categorizing patients regarding personalized care going forward. So ocular manifestations range from 2% to 32% in acute COVID. It enters through the ACE2 receptors, and these are present in the conjunctiva, limbo-superficial cells, retina, and the aqueous humor. The virus causes thromboembolic complications with reports as high as 30%. This is linked to thromboinflammation and endothelial cell injury, thought to be mediated by the overproduction of inflammatory cytokines. And studies have found that microvascular injury can directly lead to brain and nerve tissue injury. The literature to date on this topic focuses on patients post-hospitalization and within the first 6 months post-COVID. So some examples here is a study by Ibrahimi et al. Published in the Canadian Journal of Ophthalmology, who looked at patients 14 days from acute symptom onset. They found reduced mean superficial capillary plexus vessel density and DCP vessel density and decreased blood flow in these plexus. And Xephilio et al., they were published in the British Journal of Ophthalmology. They also found decreased central retinal vessel density, and they related this to COVID-19 infection severity. And Hazar et al., who published in Photodiagnosis and Photodynamic Therapy, found that vessel density is low in both superficial and deep layers, but no change in the foveal vascular zone. So far in our study, we've recruited 65 COVID patients and 40 control patients. So they've had no symptoms of COVID-19, so they haven't had COVID that they know of and no ongoing symptoms. We then broke the COVID cohort into 3 separate cohorts. So the main one we wanted, our primary outcome was to focus on post-COVID syndrome or long COVID. So we have 40 patients, they have ongoing symptoms, they've never been hospitalized, but there was a wide range of symptom severity. So for example, some patients there was one lady who was so breathless she couldn't complete a full sentence, and it ranged to people who say had still lost their sense of smell and taste, and fatigue and some brain fog. Then our second cohort, the secondary outcome we looked at was the post-hospital admission cohort. So we have 13 patients in this, and we will add to these cohorts. and we ruled out anyone who had any underlying health conditions. And then their third cohort, so we have 12 patients here, and they all had comorbidities such as diabetes or hypertension. So 5 of these patients had post-COVID syndrome, and 7 were hospitalized for COVID-19. So this is an example of the scans that were put through the Tariq software. So we analysed mean vessel intensity, as he's mentioned this, but we looked at mean vessel density, number and area of the ischemic areas around the foveolar vascular zone, and the circularity and convex area of the foveolar vascular zone as well. This is an example of the foveolar vascular zone in a patient who had severe COVID pneumonitis. The imaging was performed 5 months post a 2-week admission. So yeah, the code gives us an objective measure of vessel density and intensity. Some aspects of the code is similar to our previously published studies around diabetes, but some are unique to us in that we're analysing a larger area of the fundus. So we look at the 10 by 10 images, looking for any ischemic areas or any problems there. So what are the results of our study? So far we found no significant change compared with the control group. So in the post-COVID syndromes group, we had 40 participants, 31 females, 9 males. So it seems to really affect females more than males. The mean age was around 46 years. The time of scan was, the mean was 15.3 months, and they range from 3 months post their acute COVID to 25 months. 36 were Caucasian, 3 Asian, and 1 Black. So we also compared these then to the 40 controls, 28 females, 12 males, and they had roughly the same age and sex distribution. So 44.48 was the mean age there. All the patients had a visual acuity of 0.2 logMAR or better. And just of note or of interest, 13 of 40 did complain. So they weren't asked, they just complained as one of their major symptoms was that they have dry eyes since COVID. And 4 out of 40 have a new intermittent blurring of vision that just comes and goes. The result of the second cohort, the hospitalized cohort, again, we found no significant change here compared with the control cohort. So we had 13 participants, 7 females, 5 males, mean age of 53, and then compared this to our 40 controls. So their length of stay in hospital ranged from 5 to 21 days. The average was 11.8, 10 Caucasian, 2 Asian, and 1 Black. The vision acuity was 0.2 logMAR or better. And in this group as well, 2 of 13 had a new intermittent blurring of vision, and 1 out of 13 described dry eye. So for the result of the comorbidity group, so there was 5 patients who had post-COVID syndrome, 3 had diabetes, 1 had hypertension and raised BMI, and 1 had Ehlers-Danlos type 3. And then 7 who had been hospitalized for COVID-19, 3 had hypertension, 3 had diabetes and raised BMI. So the time of scan post-COVID was 11.36 months. And so in this, we did find significant change, and the area number of ischemic areas was significantly greater. The capillary intensity was significantly lower than the control group, and the foveolar vascular zone area was significantly greater in the cohort with comorbidities. So as we lack data or retinal imaging of these participants prior to their contracting COVID-19, the retinal damage may or may not have been present before. It is known that comorbidities such as diabetes and hypertension could lead to a more grievous COVID-19 disease, which could in turn lead to retinal microvascular damage, but obviously it could be caused by the comorbidity as well. So then the question we have, because so when we set out, we didn't know what we'd find, and then some of the studies were saying they had changes, so we were looking out for change. But what we found is that this study is very reassuring that acute microvascular changes might not persist in the long term. A possible explanation is the reversibility of any damage to macular capillary plexuses after the resolution of the acute phase of the infection, as these scans were taken 5 to 24 months after hospitalization. So it's a long time after their acute illness. And an important consideration is that our study analysed a subgroup of patients who were affected by a lower burden of aggravating systemic conditions or comorbidities compared to data in the literature for hospitalised COVID-19 patients. And none of these patients had underlying health conditions except for the comorbidity cohort where changes were seen. So overall, patients have been very, very relieved when they've had their scans done to find that there's no lasting retinal microvascular damage found. And I'd like to give a big thank you to our respiratory colleagues who've collaborated with us on this study and sending suitable patients for us to recruit. And thank you very, very much for listening.
Thank you very much, Orlaith and Tariq. We'll take questions at the end of the four presentations. It is with great pleasure that I introduce our next speaker, Dr. Prithvi Ramtohul. Dr. Ramtohul is a retina specialist. He's currently doing a research fellowship under the supervision of Professor Bailey Freund in New York at the Vitreous Retina Macular Consultants. Prithvi, thank you very much for sharing your experience with us today.
Thank you so much for your introduction. It is my pleasure and great honor to present you an overview of choroidal diseases, and more specifically the pachychoroid disease spectrum using the wide field OCT Xephilio. And I would like to thank Canon Europe for the invitation. So these are my take-home messages. En face wide field OCT imaging reveals distinctive features of choroidal venous insufficiency associated with pachychoroid diseases. En face wide field OCT imaging can also provide structural characterization of the drainage routes up to the vortex vein ampullae. And wide field choroidal thickness map may be an additional parameter to evaluate therapeutic interventions in patients with pachychoroid disease. So we all know that ultra-wide field imaging and especially ultra-wide field ICG angiography have improved our management of patients with central serous chorioretinopathy, and we are now familiar with this imaging modality. Well, all these images are en face ultra-wide field OCT imaging montage of the choroidal structure. So this is how we proceeded. We acquired wide field OCT scans at 5 fixation points, and then we used the photomesh command in Photoshop to create a composite en face ultra-wide field OCT image of the choroid. So this is an example of an healthy eye. Look how balanced is the choroidal vortex vein system between the 4 quadrants. So we replicate this imaging processing in patients with pachychoroid diseases. This is a case of peripapillary pachychoroid syndrome. You can see that the choroidal venous congestion is in the supranasal quadrant, and the infranasal vortex vein system is very hypoplasic. To me, this is one of the major advantages of this imaging technique. As you know, prior OCT modalities can provide the choroidal thickness map limited to the posterior pole. With the Xephilio, we can create an ultra-wide field choroidal thickness map of the entire vortex vein system up to the ampullae. This imaging modality may help to assess quantitatively the choroidal venous congestion. For example, in this case of peripapillary pachychoroid syndrome, we can clearly see that the location of the maximal choroidal thickness is in the peripapillary supranasal area, which is consistent with the diagnosis. This is another example of a young patient with chronic CSC. You can see the imbalanced choroidal venous drainage. Here, the dominant vortex vein are in the supranasal and inferotemporal quadrants, and the inferonasal vortex vein appeared hypoplasic. These findings are confirmed by the thickness map, which show the peripheral choroidal thickening up to the ampullae. So before we focus on the pachychoroid disease, I'm going to review cases we imaged using the Xephilio. So this is a young patient with choroideremia. It is an X-linked chorioretinal dystrophy characterized by diffuse progressive degeneration of the retinal pigment epithelium, photoreceptor, and choriocapillaris. The en face OCT imaging can confirm the loss of the choroidal layers and the preservation of a choroidal island at the fovea in this case. En-face OCT imaging can also be useful for the diagnosis of choroidal nevi. In this case, you can appreciate the absence of choroidal vasculature inside the choroidal nevus, which is a characteristic finding. We can also see that the normal choroidal vessels go around the nevus. The thickness map shows no increased choroidal thickness at the level of the lesion, which is consistent with the ultra-wide field B scan that confirms the diagnosis of flat choroidal nevus. En-face wide-field OCT may also be helpful to identify subclinical forms of choroidal venous congestion in patients with unrelated retinal disease. As you know, a pre-existing choroidal venous congestion may influence the disease manifestation, resulting in more significant retinal fluid accumulation. For instance, bacillary layer detachment is a subtype of subretinal exudation characterized by a split at the level of the photoreceptor inner segment myoid and resulting in fluid accumulation. In this case, you can see a prominent supratemporal vortex vein with pachyvessel crossing the horizontal watershed zone, which is confirmed on the en-face ultra-wide field OCT image. The thickness map also show a prominent choroidal venous congestion along the supratemporal vortex vein and in the macula. And the increased choroidal thickness colocalized with choroidal vascular hyperpermeability on the late phase ICG-A. This is the last example, a patient with choroidal hemangioma. A deeper look at the fundus photography shows an orange lesion at the level of the temporal vascular arcade. This is the typical ICG sequence of choroidal hemangioma with early hypofluorescence, progressive increased fluorescence, and eventually late washout. The en-face OCT image show the dilated mass-like lesion in this case, and the choroidal thickness map show the increased choroidal thickness at the level of the lesion. So now I'm going to present you briefly the results of our study focusing on the pachychoroid disease. We now know that choroidal venous insufficiency underlies a broader spectrum of retinal disease states which share characteristic imaging findings, including dilated choroidal veins or pachyvessel draining to dilated vortex ampullae, choroidal vascular hyperpermeability on ICG-A that colocalize with pachyvessels, choroidal thickening and vascular remodeling in areas of venous congestion. And these changes result in reduced inner flow in the inner choroid and choriocapillaries and subsequent complications such as RPE changes, pachydrasin, and macular neovascularization. In this study, Dr. Baishi and colleagues measured the size of vortex vein drainage areas in each quadrant and showed that the pachychoroid group showed significantly higher within subject variance in drainage areas size compared to the control group. This variability in the pachychoroid group was most notable in the nasal quadrants, and the inferior nasal quadrant was significantly hypoplasic. In this new study, we evaluated whether en-face ultra-wide-field OCT montage imaging can replicate the ultra-wide-field ICG-A features of choroidal venous insufficiency in eyes with CSC. So we assessed the choroidal venous insufficiency features on both ultra-wide-field ICG-A and en-face ultra-wide-field OCT images, and we evaluate the correlation between these imaging modalities. We also analyzed the spatial correlation between choroidal vascular hyperpermeability on ICG-A and choroidal thickness on ultra-wide-field choroidal thickness map. So here are the results. We included 42 eyes from 27 patients diagnosed with CSC. The correlation between ICG-A and en-face OCT images for the vortex vein drainage areas was excellent. These are representative cases of patterns suggestive of choroidal venous congestion in CSC. So the en-face OCT images show asymmetrical vortex vein drainage, and the venous congestion can be limited to one quadrant, as in the first case, or can be more diffuse, as in the third case. En face, ultra-wide field OCT can also display distinctive patterns of pachychoroid diseases, including pachyvessel crossing the choroidal watershed zones. So in this case, you can appreciate dilated and tortuous vessel violating the horizontal watershed zone in the periphery. On a closer inspection, these pachyvessels may form intervortex anastomosis between the superotemporal and inferotemporal vortex vein systems. Finally, ultra-wide field choroidal thickness map may provide quantitative measurements of the vortex vein system up to the ampullae. And thickening of the choroid colloquialized with area of choroidal vascular hyperpermeability on ultra-wide field ICG angiography. To conclude, I would like to present you a case showing how the ultra-wide field choroidal thickness map may be a useful parameter to evaluate therapeutic intervention in CSC. So this is a case of typical acute CSC with subfoveal serous retinal detachment. The late phase ICG-A showed choroidal vascular hyperpermeability at the posterior pole. This is the OCT-B scan before and 1 year after the PDT treatment, showing resolution of the serous retinal detachment. On the en face wide field OCT image acquired before and 1 year after the PDT treatment, it is very hard to appreciate any structural changes of the choroid. However, if you have a look at the choroidal thickness map, you can clearly see the reduction of the choroidal venous congestion. And I believe that this imaging modality may be a more accurate parameter for evaluating therapeutic intervention in CSC patients. I would like to thank you for your attention. I also would like to thank my faculty mentor, Professor Bailey Fern, and my co-fellow, Dr. Jogo Cabral. Thank you.
Thank you very much, Prithvi, for that excellent presentation. I think it is my turn now. Let me share with you my experience with wide field OCT in the assessment of the objective assessment of PVD or posterior detachment and the assessment of the vitreoretinal interface and the peripheral retina. These are my commercial associations. So we know that retinal examination is mostly done with slit lamp using a wide field lens. However, this is not really a retinal examination because we cannot reach the peripheral retina, the ora serrata, with slit lamp microscopy. The only way to see the ora serrata is with indirect ophthalmoscopy in some patients, but mainly with indentation, indirect ophthalmoscopy with scleral indentation. Pomerantsev, back in 1984, developed the first wide field camera, 90 degrees non-contact. This started our quest for imaging beyond the posterior pole. It's interesting that this is 1984, long time ago. There was no interest at the time in looking at the peripheral retina. He was a true pioneer, but too ahead of his time, perhaps. Optos changed the way we examine patients with the introduction of ultra-wide field technology back in 2010. And this allowed us to grow our interest and understanding of the peripheral retina. For example, in diabetic patients, we know that it is the peripheral lesions that really predict progression and risk of blindness. And this allowed us also to create and to deliver new treatment strategies like targeted retinal photocoagulation to reduce the area of laser retina. With regards to the peripheral retina, we are still relying on papers that are from a long time ago, from the 80s and 90s, and the seminal papers are from Norman Bayer. there was no advanced imaging technology at the time, as we can imagine. It was Kothari and Saravanan who carried out the first description of peripheral OCT imaging, and this was published in 2011. Here you can see some of the results using short scans, single line scans. Others, like Chowdhury, followed. This is the first OCT scanner that arrived to the UK back in 1998. This is myself carrying out OCT scanning. It was time domain technology. We had 400 A scans per second. Now we're using 100,000 A scans per second. We had 2 monitors to control and see what we were doing. Back in 2012, we published the first description of imaging the cortical vitreous using swept source technology, which was seeing the cortical vitreous in vivo rather than having to use ink in cadaveric eyes like Warsh did. And we published our results using this Canon technology last year at the European Journal of Ophthalmology, using this new navigated single capture 3D and cross-sectional wide field OCT technology. So let's talk a little bit about the vitreous. We know that by the age of 40, the firm connection between the hyaluronic acid and collagen fibers loosen up, the vitreous starts to liquefy, and we keep saying that 70% of patients in their 70s have a liquefied and detached vitreous. However, as I'll show you, this may not be the case. So what are the risks for a posterior vitreous detachment? Well, mainly aging, vitreous liquefaction, myopic eye, vitreoretinal adhesion weakens as the internal median membrane thickens with age or in a diabetic eye, surgical aphakia or cataract surgery. So the prevalence is 1.5% in patients aged 49 years of age compared to 100% in patients aged 90 and above. It is very easy to diagnose a PVD when you have a vice ring, but this is not always possible. And we have to remember that we start with early liquefaction, moving on to the growth of these lacunae, which tend to coalesce. We then have a partial PVD and then a complete PVD. And sometimes it can be incomplete with the vitreous attached to the optic nerve head. So we look at this in a couple of minutes. So of course, this is the Canon technology that we are using with 23 millimeter long scans, that's 80 degrees. But also very importantly, not only we are getting long scans, but deep scans with a window that increases from 2.6 millimeter depth when we use 12 millimeter scan technology to 5.3 millimeters. So we are able to image deeper into the vitreous. Horizontal resolution of 30 microns, axial resolution of 8 microns. Now, all of the patients that we see undergo indirect ophthalmoscopy with 360-degree scleral indentation. So with my co-investigators, with Ursula, we've looked at 148 eyes with symptoms of acute PVD or attending for a retinal examination prior to undergoing pre-intraocular lens implantation, contact lens implantation, or pre-ICL implantation. And we wanted to assess not just the peripheral retina, but also the status of the vitreous. And this is ongoing work. So when you do slit lamp eye microscopy, you may find no PVD, or you may find a clear PVD with a vice ring. But what if you do not find a vice ring? Is there a PVD? Is it vitreous chysis? Or is it a syneretic vitreous? So what do? Well, this is a clear example. You can see a nice reflex by reflection on the vitreoretinal interface. It's a young patient, clear vitreous cavity, no PVD, wide field OCT map, and a bursa primacularis, space of Martegiani, and an attached clear vitreous with not even vitreous floaters. No doubts here. This is another example where you clearly see a lacunae, a single linear floater, and an attached vitreous. This patient came to see me looking for YAG vitriolysis, which I declined to do. I said to the patient, this is not in your best interest. It's a single floater in the presence of an attached vitreous, a formed vitreous, not many lacunae, not syneretic. This is a mature patient, perfectly healthy fundus, and you can see the formation of pockets of lacunae and the edge of the bursa premacularis. It's an attached vitreous, of course, as you may remember, and I highly recommend you to read the work by Worst, W-O-R-S-T. He did seminal work on the systems of vitreous cisterns. This is another example of a bursa premacularis in an attached vitreous. So you can clearly see, you can objectively document the presence of an attached vitreous in this patient. Now, these are various examples of images of a partially attached vitreous, of a partial PVD. And here you can see the vitreous attached to the optic nerve head. Again, here, this is a patient with proliferative diabetic retinopathy, and this is a high myope with peripapillary retinoschisis and the vitreous attached to the optic nerve head. A patient with a macula-only PVD, a fibrotic posterior hyaloid, and you can see the traction on the fovea inducing a vitreomacular traction syndrome. A patient with vitreoschisis. You can clearly see the splitting of the vitreous here, the presence of a stage 3 macular epiretinal membrane, a vitreous attachment on the edge of the membrane, macular or a partial posterior pole PVD. You can see up to where the vitreous is detached. So this patient has not got a PVD. You can see another example here. We can see a posterior only PVD, the macula, the fovea, the optic nerve. You can see floaters, you can see the ongoing syneresis, and hence the partial PVD. Other examples, you can see vitreous floaters here, you can see a posterior pole PVD, thickened internal limiting membrane, stroke early epiretinal membrane, clearly visible PVD. You can see PVD with a corrugated posterior hyaloid. Vice ring. You can see a vice ring very clearly, and you can see the shadow cast by the vice ring, and hence the symptomatic floaters. Again, a vitro optic nerve head attachment in the presence of proliferative disease, and a more peripheral here vitreous attachment along the vascular arcade with already some schitic changes indicating chronic traction. You can see the cisterns and the tongues, as I call them, of vitreous gel. This is a 3D reconstruction of a PVD and the vitreous floaters. A partial PVD, there is a cleavage plane only between the posterior cortical vitreous and the optic nerve and the fovea with vitreous floaters. So no PVD in this patient. So the presence of floaters is not the reason to diagnose a PVD. Here we have a PVD. The PVD extends beyond the field of the OCT scans. So it is very important to be able to diagnose a PVD, not only in the symptomatic eye, but also in the fellow eye. And we'll go back to that. So let's move on to imaging the peripheral retina. We start with this image. This is a patient that complained of symptoms of acute PVD, shutdowns to floaters, flashes of light. I could only see this clearly on indirect ophthalmoscopy. When I first looked at the ultra-wide field image, I missed this, and I did indirect ophthalmoscopy. This appeared elevated, and then when I went back, it was obvious that there was something there. And look at the navigated peripheral OCT. This is the topography map, the vitreous attached, and the tear and subretinal fluid. And as you can see, this is the 3D rendering of that same lesion, an area of schisis, and you can clearly see the peau d'orange and the 3D rendering of the area of schisis. A nice way of showing the patient that part of the retina, that the outer leaf, it is still attached and that no treatment is needed. This is a patient that came to see me a year ago, a Russian model with symptoms of no, she didn't. She was asymptomatic. This is what made it more challenging. She was asymptomatic and she wanted to undergo ICL implantation. Now, on indirect ophthalmoscopy, I could see there was subretinal, well, there was elevated retina anterior to this area of lattice with these two possible rhegmatogenous lesions, and look at the OCT, clearly showing the vitreous attachment and the solution of continuity and the subclinical RD. So, and here you can see the 3D rendering of this patient, the vitreous attachment, the elevated and detached retina. She declined having laser retinopexy at the time to try to prevent the extension of the fluid. And here you can see the topography map. We'll come back to this case. This is a patient where, to me, it clearly looked like a hole with subretinal fluid. You can see the halo. However, OCT scans proved me wrong. There was no full thickness retina. There may have been traction here, which induced schisis, schitic changes. So no treatment was necessary. Had I not had the availability of peripheral OCT, I would have ended up lasering this lesion, believing this was a hole with SRF. This looked like a flat disc of fibrosis, but look at the 3D rendering, clearly not. This is what I call a giant vitreoretinal tuft. Looks like one of those sea creatures that resemble coral, and the vitreous attachment. Now, this is a patient that underwent elsewhere, multiple surgeries, and came to see me for a second opinion. Wide field, single scan fluorescein angiography showing good perfusion in the remaining retina. The topography maps and clearly the cross-sectional scans show the area of detached retina. And this is very useful to ascertain where the retina, where the edge of the retinotomy is elevated, where it is still attached, and of course a macular hole. This is the 3D rendering, clearly showing the area of detached retina inferiorly. This is another patient that came for a second opinion, and it was very easy to explain and show to the patient the reason for the lack of improvement in vision. The topography map clearly illustrates the area of thin retina, unfortunately going through the fovea. We can see in the 3D rendering this persistent fibrosis, stalk of fibrosis linking the optic nerve head with the peripheral remaining vitreous. The contralateral eye, the scans show the presence of retinoschisis nasal to the optic nerve head. This is one of the last cases that I want to show you. The practical value of peripheral navigated OCT. here you can see retinoschisis, but you always want to know whether there's any retinal detachment as a component associated to the area of schisis. And here you can clearly see the area of retinal detachment in the 3D rendering, in addition to the area of schisis. We do not treat schisis, but we do treat retinal detachment, of course. Another example of PVD. This is a 3D rendering. You can see the corrugated posterior hyaloid, which makes the PVD much more symptomatic. But there is a lot of value in peripheral OCT because it is important to know whether the PVD is complete or not. And here we can establish how peripheral the PVD has reached. And here you can see the 3D rendering, the vitreous floaters. We have to remember that OCT can have artifacts, and here you can see, you see not a tear, but shadow caused by this floater. And this is the imaging results of that Russian model, and you can see the progression of the subretinal fluid following her decline of treatment a year ago, and we've repeated the imaging and been able to carry out treatment a month and a half ago. So in conclusion, wide field and ultra wide field imaging have an increasingly important role in screening, diagnosing, monitoring, and treating retinal diseases. This is a new OCT technology, navigated, non-contact. There's no need for a lens attachment. It's single scan based on infrared swab source technology. We can say, I believe, that diagnosing the peripheral retinal pathologies and PVD objectively is a landmark achievement, not only with importance for the symptomatic, but also for the fellow eye. If a patient comes with acute symptoms of acute PVD, it is important to be able to tell the patient whether they are at risk of developing a PVD in the other eye or not. In the absence of a retinal specialist, in the absence of a surgical retinal specialist or a specialist that can do indirect ophthalmoscopy with 360-degree square dentation, peripheral scanning, as I've shown you, can be very helpful to diagnose and time referrals. It is very important to be able to see the retina up to the edge. Slit lamp biomicroscopy, as I say to my fellows, is not enough. If you see a patient with acute PVD and you just do slit lamp biomicroscopy, you are not examining the retina. You are just examining the posterior pole. So this is a powerful diagnostic tool that provides high quality, clinically meaningful images which can change clinical management. I would like to thank my co-authors, my team, Dr. Ursula Reinstein, Nasma Farouki Bashir, Francia Villar, and of course, Ori. Many thanks again, and please don't worry because we will accurately diagnose your peripheral retinas. I would like to invite all of the speakers to turn on their videos and microphones and join me for a roundtable of questions. We've got a first question from the audience, Orlaith. Have you looked at the thickness of the retina in your study?
So we've obtained OCT images, fundus autofluorescence, and color photo images. So we will, that is something we plan to do. We haven't noticed any difference, but formal analysis is planned for the retinal thickness.
And Prithvi, beautiful images of the choroid.
Thank you.
Is there still place for ICG in everyday clinic, or do you think OCT angiography is there?
That's an excellent question. I think that using OCT, we can have beautiful image that can characterize the choroidal structure, but ICG angiography may be useful for assessing choroidal vascular hyperpermeability. And this finding is mostly used to treat CSE patients So for now, I think that ICG-A may remain a required imaging finding prior treatment in CSC patients. Yeah.
Tariq, there's a lot of concern about artifacts in OCT angiography. What is your take on it?
Yeah, so Orla did a great presentation looking at this system of analysis, but one of the real challenges was to get good quality images. It was something that the Canon helped a lot with, but even with the best one in the world, there would still be artifacts. So we did two things. One is to use the automated system of image quality to ensure that there was good image quality in all images taken. But then also sometimes you do sometimes see floaters even, don't you? And if you take a single image, you can get little dark areas in that image. And this is just something we realized later on, that the software was finding areas that it thought was ischemic, whereas actually it definitely wasn't. And we could see when you're taking the image that these things were moving. So we incorporated aspects into the software to try and counteract those different artifacts that came up as well.
And this is a question for everyone. Are we there with OCT angiography for using it in everyday clinic? Do you use it in everyday clinic? Let's start with Prithvi.
Yeah, I mean, in New York, we use it every day for imaging macular neovascularization. So most of the patients we treat here are macular degeneration patients. So we mostly use OCT angiography for all our patients, yeah.
Orlaith?
Tariq can talk for me because I work with Tariq.
Sorry, you can answer that all if you want.
Yeah.
To.
No, you can go ahead.
Okay, don't fight. We need one to answer.
I'll answer it then. So I think it's a really useful tool, even just so as well as for the macular OCT-A. I'm really keen on the wide field OCT-A as well for the diabetic patients, for identifying those in neovascularization. And we're having a problem with occasionally people can have things missed. We don't get fluorescein angiograms in the same day in clinic, like in some places. So being able to shove them over, get an OCT-A and see very clearly this neovascularization, and then they can move straight to laser, I think is a really useful tool. So to my mind, it should be a part of every retinal practice, and it's what I'm trying to convince people of. Can I ask you the same question, Paulo, about, because your images were absolutely awesome. It was great seeing those images. And one of the things that come to my mind is that actually this shouldn't just be with Paulo, this should be with everybody, because our indirect skills are getting worse and worse. I'm speaking for myself and probably a lot of other people. And actually, if we've got this imaging coming up, if we could be missing things or treating things that aren't actually there, do you think that sort of wide field imaging that you're presenting should be in the mainstream now as well?
Thanks for the comments and the question, Tariq. I do. I think, well, acute PVD, we see a lot of patients. You want to be objective. We see a lot of patients that were seen elsewhere and they were told that they have a PVD. And I believe in indirect, but I'm a retinal surgeon, I believe in indirect ophthalmoscopy with 360-degree scleral indentation. Perhaps I'm privileged because I don't do 70 patient clinics for obvious reasons. But we do all our research here in-house at the Retina clinic on Harley Street, and every patient undergoes wide field OCT imaging. Everybody undergoes indirect ophthalmoscopy with 360-degree scleral indentation. Now, there's no technology. There's a question that has just shown up that ties well with your question, Tariq. It says, Professor Stanga, do you really think that peripheral OCT is superior to indirect ophthalmoscopy in investigating peripheral lesions? I have experience with Spectralis platforms since years, and even if OCT often discloses unexpected surprises, it is often difficult to image very peripheral lesions. Yes, that's why we cannot replace indirect ophthalmoscopy, but we can complement indirect ophthalmoscopy. We should not think of replacing, we should think of complementing. They provide different information. And that's why I made it very clear, all of the patients I've examined have undergone indirect ophthalmoscopy. There's no method, no imaging modality, to the best of my knowledge, that can reach the ora cerebrati in all patients. Of course, there are patients that have a posterior ora where you can image with ultra-wide field imaging, or you can scan the ora, but in most patients you cannot. So it is important to include indirect ophthalmoscopy in all of the examinations. But traction, if you want to document it, you need OCT. Peripheral OCT to document fluid. OCT is very good. Sometimes you have peripheral lesions that you don't know whether they are elevated or not, as I've shown you that the giant vitreoretinal tuft. So I think we need to talk about complementing rather than replacement of technologies. We live in an era of multimodal imaging. So I don't think anybody expects that we are just going to use one technology. So thank you for the questions.
Can I ask another question? Can I ask another question? I'm really sorry, Paulo. I'm really desperate to ask Prithvi, because I just want to know the answer, and it's not necessarily directly from your talk today, but can I ask what you guys in New York are doing for CSR patients now that you can't do PDT? I'm interested to know what you guys are doing. Are you using subthreshold laser, or are you using a plenarone? What's your go-to treatment?
Oh, you mean for CSC patient, right?
Yeah.
Yeah, here in New York, we only use PDT treatment. We do not use eplerenone anymore, since the result of the last randomized trials have shown the efficacy of eplerenone was inferior to PDT. So yeah, we only use PDT treatment in New York.
Do you not have a shortage out there?
Sorry?
Do you not have a shortage of verteporfin out there?
No, I'm not really sure about what is I mostly do here. Yeah.
Thank you. Sorry, Paulo.
No, that's okay. Prithvi, do you diagnose, talking about CSR, do you diagnose CSR based on ICG, OCT, or both?
I would say both, and also on fundus photography features. So yeah, we use ICG angiography in all our CSC patients, especially if we want to do PDT treatment. So we do ICG AB for treatment. And now we're also investigating the wide field OCT imaging on this patient. So we also do this imaging on this patient, yeah.
Orlaith, how would you like to see OCT angiography in 5 years' time?
So I think it's after making such changes already in just the last few years, but just to continue with things like, I suppose, the project artifact removal, you know, if we could get around some of the limitations that are still there. But yeah, I definitely think it's going to become more and more everyday clinical practice, and it should become that way.
Tariq, same question for you.
Well, I think that we can reduce the amount of fluorescein angiograms we do quite a lot. I think that the OCT, especially wide field OCT, is really beautiful. I think there can still be improvements to other plexus, like the deep capillary plexus, for example. Sometimes some of the fine detail of that can be lost. But every year when I give these talks, there are more and more indications for it. I think there needs to be more teaching and training on it. I think it's a harder modality to interpret than OCT. So I think that explains maybe some of the resistance, but the potential for it in terms of information it gives is really great. So I'm looking forward to more panels like this in years to come, and seeing what colleagues are doing with the technologies.
Prithvi, last question for you. Or asking for comments. Choroidal venous congestion. It may be that it is being significantly overlooked. Is that the case? Are we underdiagnosing choroidal venous congestion?
Yeah, that's an excellent question, and that's what I wanted to suggest at the end of my talk. And maybe a lot of patients may show a pre-existent choroidal venous congestion that can influence the disease phenotype, and some patients may show very large exudative signs that can fool you for the diagnosis. So I think that if we can diagnose the subclinical forms of choroidal venous congestion, it can increase our understanding of some manifestations of some disease. Yeah.
Well, I think we have to come to a close because we've gone over the hour. So thank you to the three of you, and especially to Canon Medical Systems Europe for organizing this webinar. Ori, thank you very much for doing so. And we look forward to seeing everybody again with more scans, more interesting scans. Thank you.
Thank you, Paulo. Thank you,
Thank
colleagues.
you. Thank you.